Um, Good morning, everyone. My name is Matondo Ngemba. I'm a healthcare professional at Cleveland Clinic. I have a background in international relations and pursuing a master's in public health. I'm from the Democratic Republic of Congo, and I work very closely with my community here regarding public health issues and female youth empowerment. I hope to continue my career working with Doctors Without Borders as a healthcare profession upon completing my medical studies. It's an honor to be with distinguished panelists like you, and I hope to learn more from what you're doing around the world. If we could just go around and also introduce ourselves, we have about like 5 minutes each to talk about who we are and where we're doing. So we can start with Dr. Rabbani.
Thank you so much. It's a pleasure to join. And My name is Ehsan Rabbani. I manage a non-profit organization which treats about 1 million children a year. And I believe that these are my 5 minutes to talk about the health innovations. Is that correct?
Yes.
Okay. The challenge that we face is that the number one mortality in Pakistan is of children under 5. About 400,000 children die every year before they reach the age of 5. And to address that, the solution we have picked up is improving the quality of care at the emergency rooms of government or public hospitals, which are totally free. So today we manage about 10 children emergency rooms in government tertiary care hospitals, which enables us to treat about 1 million children a year. We do this at a cost of about $7 per child. And most importantly, the survival rate in the resuscitation rooms has increased from 20% to 90%. Now, in addition to doing the tertiary care hospitals, we have used a technology to reach out to secondary care hospitals through the help of a camera and a nurse placed there. And we consult a command using a command and control center. And what we are able to do is treat the child remotely. And this helps us do one good catch per hour. And what we have been able to do is go beyond making a difference to now impacting the system. So we have now got about 10 satellite centers, and government has partnered us to increase it to cover all 100 hospitals. In terms of health innovations, we feel what we are able to do is have impacted the health system by scaling up, by replicating a successful model. We have also improved quality by measuring key indicators for doctors, which is usually very difficult thing. But we measure it using some indicators on competence, compassion, and compliance. For example, on competence, we measure how many prescription errors they make. Are they doing their continuing medical education? On compassion, we measure patient satisfaction, and on compliance, we measure compliance to medical protocols. Another health innovation we do is we are able to encourage, measure, and implement teamwork, which we do through a 360-degree evaluation. That's a health innovation because no hospital can run without teamwork. And another measurement is how satisfied our patients are. So we use for these free patients, send out an SMS to them, ask them for feedback, and include that in the performance appraisal of doctors. So we are a work in progress, 10 years on. We hope that another 10 years we will be impacting about 5 million children a year. I hope to get some queries and questions from your side to be able to improve our model. Thank you.
Dr. Rabbani. If we could have Ms. Chisomo Selamani give us also a brief introduction about who she is and what she's doing.
Hello, everyone. My name is Chisomo Selamani. I'm an assistant professor at Baldwin Wallace University, and I'm an associate professor at Baldwin Wallace University, newly tenured, that's why the mistake. So I'm going to share my screen with you, and just as a tip for all of you who are participating, if you double click on the on my picture, you should be able to see my PowerPoint slides a little bit bigger. So here we go. I am also the coordinator of what you're going to learn a little bit more today about, which is the Baldwin Wallace in Zambia program. So here we go. You should be seeing my PowerPoint slides. And like I said, if you can double click on my image, then this should be the biggest screen on your screen. So from B to Z, leveraging minority world and majority world interactions for social change, the Baldwin Wallace in Zambia program. So you see here two numbers, 92% and 1 to 4 million. And underneath them, you see places in the world, right? So what is 92%? What's happening in the US is 92%. And what's happening in sub-Saharan, that's a ratio of 1 to 2 to 4 million people. So in the United States, 92% represents the percentage of people in the American Speech, Language, and Hearing Association. So that consists of audiologists, speech pathologists, and other healthcare practitioners specific to speech and language therapy, or specific to communication sciences and disorders. 92% of these individuals identify as coming from the majority perspective. So that means that we have only about 8% of practitioners that identify as being from a racialized minority. So think about that. So of all the service providers in the United States, only about 8% of them are able to treat, or not are able to treat, about 8% of them identify as coming from a racialized minority. And so therefore, we have a discussion within our association, and the American Speech, Language, and Hearing Association is doing a lot of really great work in introspection as we look at barriers for participation in the field of communication sciences and disorders in the United States. And so I'm an associate professor of communication sciences and disorders. I'm a speech pathologist, so I'm one of the 8% here. So in Zambia, and more broadly in sub-Saharan Africa, this ratio you've probably figured out by now that I've said communication sciences and disorders multiple times, that this has to do with speech pathology. And you would be correct if you were thinking that. The ratio of 1 to 2 to 4 million people is the approximate number of speech therapists to populations. So in each country in sub-Saharan Africa, there's approximately 1 speech therapist to 2 to 4 million people. So if you know anything about hearing loss or language disorders, swallowing disorders, children with developmental concerns, autism, all of these things, you're probably thinking, I know at least one person with one of the disorders that Chisomo just named. And so we as speech pathologists endeavor to work with those populations, but we have some critical challenges when our workforce may not be as equipped to serve individuals, or we don't have enough. We have a deficit in the workforce. So it is at the intersection of these two issues that the Baldwin Wallace in Zambia programs was incepted. And so we engage in innovative practices because we truly do work to be a bridge across communities in the United States and in Zambia. And so our students, who the majority of whom are coming from the majority perspective, coming from a Caucasian perspective, when they come to Baldwin Wallace, are wonderfully excited, great individuals, often have not thought about leaving the country, have not had a whole lot of experience with difference. And so through our study abroad wing, we're able to take these students to the world and and learn. They get to learn from the world. So we take the students to the world and we bring them to our students. So in our innovative practices, our hope is to center partnerships by co-authoring agendas, getting insight from our advisory board in Zambia. We have a model that everyone learns. So whether we're talking about faculty who are traveling to Zambia, students who are traveling, our community partners, everyone is learning together. And we do telehealth as well. We've got a telehealth research wing. And as I said, culturally responsive practices are at the heart of this. So as I mentioned, the pillars of the Baldwin, Wallace, and Zambia initiatives are professional development, international education, and community engagement. Here in the community engagement photo, we see, this is a picture of Baldwin Wallace faculty with the First Lady of Zambia. And this is important because we are seeking to move the needle forward with our community partners, including government and community engagement. So as we do these things, as we work to educate future speech therapists in the United States, and as we work to change the landscape of speech pathology in Zambia through telepractice, through professional development, through a variety of different endeavors, we ask the question, what miracle will happen today? This is a quote from one of our caregivers who is involved with telepractice. I believe that is my time. Thank you so much. And if you have any other questions, feel free during our discussion to ask them.
Thank you so much. Now we're going to have Matt Gill give us a brief introduction about himself and what he's also doing. And just a quick housekeeping,
Sure.
if you're not talking, if you could please mute your mic so that we don't get the feedback.
Sure. So thank you very much. It's very exciting to be here as an Ohio native and a Cleveland sports fan, so go Browns. I'm, as you mentioned, my name is Mati. I'm here in Israel, based in Tel Aviv. And I'm honored to be here representing Teva Pharmaceuticals, the company that I work at, which is the largest Israeli company and the leading provider of medicines in the United States. It's also a global leader in generic medicines and biopharmaceuticals. And in that sense, I think the reality that we're all dealing with, the fact that this conference is on Zoom or on a video conference and not face-to-face with the recent pandemic, COVID-19 has taught us that, friends, and we need to work together across borders on healthcare collaboration. And Teva, of course, has been working in that spirit. We make up over 10% of all the United States drug supply. And our role as critical suppliers to the United States has been ever so evident in our responses to COVID-19, where we've been focused on ensuring that our global supply chain, with over 60 factories in the world, fully operates and medicines reach patients here in the United States and elsewhere throughout the world, where we operate in over 60 markets. We also are taking as a top priority, making a top priority to ensure the health of our workforce of the over 40,000 employees that work at Teva Pharmaceuticals throughout the world, including the 7,000 that are in the United States and the over 400 employees in the state of Ohio that Teva employs. We, of course, are working with governments at the city, state, federal level, anywhere throughout the world, and healthcare systems and providers to support anything we do to curb the impact of the virus. As I mentioned before, I'm not just based in Israel. Our company was born in Israel, and we've enjoyed a long-standing good relationship with the Cleveland, and had the opportunity to host some of your delegations here. We are the largest Israeli company operating in the United States. We started as an Israeli company right now, just about 120 years ago, right outside the old city of Jerusalem, right outside the Jaffa Gate, for those who have had the opportunity to visit here in Israel. But we've grown, especially over the last few decades, to be the world leading provider in medicines and innovative biopharmaceuticals, with just under $17 billion in sales, and we operate in over 60 markets around the world. The U.S., the United States, is the most important country for our and market for our company. We are the leading provider of medicines in the United States, especially generic medicines, which contribute directly to the sustainability of the U.S. healthcare system and help drive down costs for patients and providers, and savings that are attributed directly to Teva. We save the U.S. healthcare system around $42 billion per year, based upon studies that we've done in recent years, independent economic studies that we've done. Those $42 billion in savings that Teva drives to the U.S. healthcare system include also $6 billion in savings directly to patients and out-of-pocket expenses. Teva also is an investor in the United States, so we employ around 7,000 Americans, and we support more than 57,000 jobs in the United States. And as I mentioned, we also are an investor in the state of Ohio. We employ over 400 people in cutting-edge, high-technology manufacturing of essential generic medicines. And we also save the Ohio healthcare system over $1 billion in savings, roughly around $1.7 billion in savings every year. And we've recently launched innovative drugs in the United States, which were based on American biopharmaceutical research, including one for migraine and the other for Huntington's disease and tardive dyskinesia. And as we look towards healthcare innovation in the future, where we have grown based upon the legacy of innovation in science and business models, both from Israel and the United States, we are looking for new ways to partner. And over the last 3 years, Teva has expanded our innovation outreach with academia and startups, looking for new ways to partner innovation, and because we understand that innovation will be ways of doing things. Just recently, just last week, we launched a new digital therapeutic medicine, a connected inhaler to help treat asthma and other respiratory diseases. It's a new way of doing things where you connect the actual medicine with a new type of medical device, and it was approved by the FDA and launched as a connected in real-time inhaler so that patients can improve their adherence and also connect with their physicians and receive real-time warnings in advance when they will be more susceptible to an asthma attack or any other type of respiratory disease. So we are looking also for new ways to innovate. That specific medicine was based on a startup based out of the United States with Israeli talent as well that Teva acquired and developed and brought it through FDA approval. So we are looking for new ways to innovate, and we're also looking for new ways to train the next generation of talent, to identify and train the next generation of biopharmaceutical talent. Recently in Israel, we launched a National Bioinnovators Forum to help train and mentor the next generation of Israeli scientists. And we hope to take this model and build on its success and build a bridge throughout the world and replicate it probably in the United States and elsewhere. And this type of forum builds a bridge between academia and industry, where we took 28 top PhD and postdoc students, which were selected by universities in the areas of biopharmaceuticals throughout the state of Israel, and we are putting them through a very rigorous training program by Teva R&D management to help boost their academic innovation capabilities into drug discovery. And not least, we are also partner in a medicine digital health incubator in Israel called Sonar, which does do collaboration with various academic institutions and hospitals in the United States as well. Sonara Ventures is a government-funded incubator where we have over 15 startup companies that have gone through that are in the portfolio of the incubation stages. Where we in the incubator, what our goal is to help identify and develop cutting-edge healthcare technologies, and startup can help improve healthcare in the United States and Israel and elsewhere throughout the world. So thank you for having me. Again, it's good. It's very good and honored to be. I'm very good, honored to be here. Excuse me, and happy to answer any questions if there are later on. And good luck to my other distinguished panelists here.
It's an honor to have you here with us too. Um, Next, if we can have Ms. Rasheeda Larkin. And then I would like to ask the rest of our panelists to turn on their cameras so that we can have more of a discussion feel and less of a presentation. Thank you.
Well, good morning, everyone. Thank you so much for having me here. I'm extremely honored to be here today, so thank you so much. So to give you a little background, I am a program manager of public health at Cleveland Clinic, and I work in the area of Cleveland Clinic community care. And we call that area 4C, but I would say the biggest C in that area is community. So I'm all about bridging clinical care with community and looking for ways to have better outcomes. So let me tell you a little bit more about what I do. When we think about public health, we think about all the things that are going on right now. I mean, Cleveland, the city of Cleveland has recently declared racism as a public health crisis. So now we're seeing racism as a public health issue, especially when we look at the ways that racial disparities have manifested themselves, not only in healthcare, but when we think of things like the penal system, when we think of housing, when we think of redlining in Cleveland, which is one of the most historically segregated cities in the United States, when we think of food insecurity, air quality, all the different ways in which racial disparities manifest themselves and show up, and how those clinical outcomes for Black and Brown people specifically, how they tend to fall behind the curve because of racism. So that's one project that we've been working on, in addition to, of course, COVID-19. We're in the midst of this public health crisis and what it looks like to community. And a lot of things is about education and making sure that our communities are aware of prevention tactics and just testing and things like that. Also, issues around lead in the city of Cleveland is also a public health crisis. So a couple of years ago, everyone was up in arms about Flint, Michigan, which we should be. No one really noticed that the city of Cleveland in certain areas, particularly in Glenville, which is a neighborhood in Cleveland where 1 in 3 houses is impacted by lead. Whether researching the children that are growing up in these neighborhoods, and they see how the trajectory has been impacted, whether educationally, causing other chronic health diseases, and also their interactions with the penal system as well. So when we look at public health, we're looking at it from a broad spectrum. But what I am here to talk to you about today is infant mortality. And this is a topic that is very near and dear to my heart and very personal to me. So I'm very dedicated and passionate around it. So Cleveland Clinic has an internal infant mortality task force. This is a task force that I manage, co-leading it with other executives such as our chiefs of women's health, pediatrics, and community care as well. So this conglomerate team comes together in a way with the goal of how can we make sure that we not only eradicate infant mortality, that would be great, but I guess the first step is how do we make things equitable? So let's give you some background on the city of Cleveland and Cuyahoga County. Infant mortality in the United States, about 5 to 6 out of 1,000 babies pass away in the United States under the age of 1. In Ohio, about 7 out of 1,000 babies pass away under the age of 1. In Cuyahoga County, around 9 babies out of 1,000 pass away under the age of 1. And in certain parts of Cleveland and bustling suburbs around Cuyahoga County, we have up to 19 out of 1,000 babies that are passing away under the age of 1. And when we break those down and when we look at the disparities between Black and white babies, what we are finding out that in some areas of Cleveland versus other areas, when we look at the disparity between Black and white babies, we see that Black babies are passing away at 4 times the rate of white babies in the area. And you might be thinking, like, why are babies dying? What does this have to do with anything? What's happening in Cleveland? So I'll give you an idea. What we know is about 55% of our babies are dying due to prematurity. So that is our biggest issue, is prematurity and extreme prematurity. We also know about 17 to 18% is due to birth defects, and about another 15% is due to unsafe sleep practices. And when we think of the disparities, and we think of Black women and Black babies losing their lives in this fight, we're thinking like, was it a socioeconomic issue? And it's not, actually. So what we find out is that when we look at insurance coverage, about 50% of our babies are covered by Medicaid, and about the other 50% are covered by private insurance. So we know that it's not a socioeconomic status either. If you were to ever look at a map of Cuyahoga County, and if you were to look at these maps that kind of tells you where the issues are in the community, so whether those issues are chronic health issues, whether it's housing issues, whether it's education issues, and even if it's infant mortality rates, if you put those maps on top of one another, it's the same exact map. So what we know is that these issues are historical, and that we can put a goal out there and say, oh yeah, we want to eradicate infant mortality in 3 to 5 years. What we know is that we can make a huge impact in 3 to 5 years, but we know that these issues in Cuyahoga County specifically has been happening for the last 70 years. So not only is it just put in a clinical intervention, is what do we do to partner clinical and community to make it a sustainable effort? In addition to Cleveland Clinic having their own internal infant mortality task force, we also partner with First Year Cleveland, which is a city-county government, community, business collaborative. And we come together with solutions to assist women in the community and what we can do as well. So a huge partnership there. What I want to talk to you about today specifically, that's just some the innovation that's happening on our behalf, which is not very innovative. When you think about it, it's something that we used to do hundreds of years ago. And I think just in clinical care, we've gotten away from that. And the biggest thing in the beginning of this session, I talked about Cleveland Clinic community care, and the biggest C there is community. So our goal in being innovative is really providing more grassroots opportunities to engage with our patients outside of the 4 walls of Cleveland Clinic. And what does that look like? And I'm going to tell you why that's important. What we know is that 20% of your overall health, 20% of your health depends on your clinical care. The other 80% is everything that happens to you outside of the walls of that hospital. So that's where you live, that's where you work, that's your stress levels, that's your housing situation, it's the food that you eat, it's the air quality that you breathe in, it's everything else that determines how healthy you are. You cannot come into the hospital at all, and still 80% of everything else is right, you'll be pretty healthy. So what do we do to partner with our community partners that's out there, and what are we doing to engage with our moms? So the first thing that we're doing in the midst of COVID is having virtual community baby showers. So this is our way of doing 3 different things. First, we want to educate moms. We want to educate them on some of the issues of infant mortality. I want to go back to what I said earlier. Over 50% of the babies that are passing away under the age of 1 is due to prematurity. Why are moms giving birth prematurely? Because they're stressed. Stress is the #1 factor. It's not because moms have chronic health diseases. It's not because any of the situations that's happening around them or to them. It's because of the stress. The stress of a Black woman or a woman of color living in Cleveland, what that looks like, the way that they're treated every single day in their neighborhoods and even in the hospitals. So how can I let them know, or how can I support them in alleviating their stress? That's #1. Education, talking to them about things that are, that's some cultural stigma around it. For example, whether it be breastfeeding, where we know that the disparity in initiation rates are extreme. where we have 80% of white women who at least initiate breastfeeding in the hospital, and only about 45% of Black women that initiate breastfeeding. We know that there's cultural stigma and a really traumatic history around Black women and breastfeeding, and that it's not normalized in Black communities. So what can we do to assist in that? So we're there to educate, to celebrate their babies, of course, and to empower. But our biggest connection in these virtual community baby showers is to make sure that each and every woman is connected to resources in the community, regardless of their socioeconomic status. Why is it important for me to make sure that they're connected to a community health worker or doula or neighborhood navigator? Because I know that mom has a 50% better chance of having a healthy birth and a healthy first year outcome for the baby. Why is it important for me to make sure that we invite her to Melanin Rich, which is our exclusive safe space for Black and brown moms who are looking to educate themselves or get support regarding breastfeeding? Well, it's important for me to get her to that resource to make sure that she feels encouraged and empowered to breastfeed, because breastfeeding drastically decreases the rate of which a baby could die under the age of 1. So making sure that mom is connected to any resource in the community that she needs. In addition to that, making sure that she has additional clinical care. We know together between clinical and community that we can make sure that the moms in our neighborhoods are taken care of. And we can make sure, the one thing that I don't want to say in 25 years is that we lost another 6,000 Black babies. 25 years from now, I don't want to say that we've lost classrooms of kindergartners that could have been here to help change the world. So we're hoping that this connection between the clinical community and the community resources will allow moms and babies to thrive past that 1-year mark. Thank you.
So much. And now we have Mr. Andrej Pantar. I pronounced that right. You could also give us a brief introduction about yourself and what you're doing.
Cleveland, thank you for inviting us to the Sister City Conference. Do you hear me well? You can double click on the presentation to make it larger. So we took this opportunity as an official launch of our new innovative rehabilitation solution with mobile health technology called Connectedm Health. Our vision with this solution is to put patients first and to digitalize the rehab concept. So let me introduce me. First, I'm Andrej Pantar, representing Mikropis Corporation, a global vendor for corporate wellness, which is a joint venture with Mayo Clinic. And we're actually co-owned by Mayo Clinic with a goal to digitalize preventive evidence-based health programs and offer it in engaging mobile app and portals. So let's talk about Connectedm Health. This is actually a game changer in the industry. It connects the patients and the clinic, even when a patient leaves the clinic, when it leaves home. And very important in this COVID-19 situation, where patients were unable to come on site for a treatment. This platform enables the clinic to better deliver rehabilitation plan to the patient's phone, enables digital tracking and the patient's progress and feedback. Well, who can take advantage of this innovative solution? Well, clinicians, physiotherapists, kinesiologists, nutritionists, even wellness experts, sports trainers, and of course, the patient himself. It's fast, intuitive, engaging, and user-friendly. So as a cloud solution, therapists can actually use it from any device, choose the exercises and protocols from a library, and the patient get them on the smartphone. The app shows what you need to do today. You can imagine how patients were unable to visit the clinic during the COVID-19. the clinician can build and deliver and track the patient's progress and even feedback. We can improve with this solution the patient's health between the medical visits. Here you can see the guided user experience, very fresh and polished design with only one button on the screen to make sure that any kind of user can use it, from seniors to teenagers and all in between. The app can be personalized and branded by the clinic name or provider, and includes motivational notifications, reminders, and call to action. We are actually improving that call to action for the patient. We know that connectivity is important. Activity trackers, heart rate monitors, and blood pressure devices could be used with the app. Real-time heart rate monitoring, yes, it's included. And perhaps see how it works. I have here a video and we can roll it out. So thank you, Sister Conference, for the opportunity. For any questions, I'm available via LinkedIn and our webpage. Thank you so much.
I believe we've heard from all our panelists. And now we'll open it up for Q&A. I have received one question, which I'm going to read. So someone asked how each of the panelists, what you presented, how you connect that with the community, and to improve public health access for those who do not have access to those resources. So to repeat it again is, how do you connect to the community and help them improve public health access?
Well, I can take that first.
One who feels
Our way of connecting with community is really on a couple of different levels. First, we do a lot of ground roots work, and that's surprising for a big enterprise like Cleveland Clinic. But prior to COVID, we were really connecting with local grocery stores, with places where the community were in and out of, where there's grocery stores or places in the community where communities were convened. In regards to a lot of our pregnant moms or expected families, we will also connect with community health worker organizations. And even though the healthcare institutions in Cleveland has historically been competitive, this is an area, since we are all passionate about saving the babies in our community, this is an area where all of us are in this together, and we really bridge those bridges between the hospitals and the family health centers and all of those different places in Cleveland. So I think just working with other healthcare centers, with the business communities, with media, local media, and also just feet on the ground, getting out there, partnering with our faith-based partners, and being willing to be in the community in a non-traditional sense, opening our minds and our hearts to that. So once the community sees us out there at places that they normally would not see us, now they begin to trust us more because they know we're willing to come to them and we're willing to meet them halfway.
Hi, can I jump in next? So I love everything that Rasheeda said. I think that at the heart of public health is partnerships, recognizing and leveraging the connections that we have in order to provide educational access to education, access to healthcare, et cetera. And so in the case of the Baldwin, Wallace, and Zambia initiative, we really take cues from our partners on the ground in Zambia. And so we go into communities where our partners are active. So the Starkey Hearing Institute is one of our primary. Our students learn together. And so we'll go into remote areas outside of the capital city. When we go to Zambia, we're often in Lusaka. We also have technology to be able to access those who may not be able to have access to speech therapy. And so when we work between minority and majority world communities, so the United States being in the minority of the world, often called first world, Zambia being in the majority of the world, often called third world. The minority-majority world contrast makes a lot more sense because minority and majority. But when we work across those levels, we have to be careful about power and privilege. And so we don't ever go into communities saying that we have answers. We go into communities trying to find answers together and provide whatever support that we have. So we listen to our partners, we use technology, we consult, we provide direct services using telepractice as well. So technology has provided some wonderful ways for us to be innovative.
Just mention three things from our side. So number one, regarding access and contribution to public health, as a leading provider of generic medicines, again, where we help drive affordability and accessibility of patients to medicines, we are very much at the heart of what access is as a purpose. Again, 10% of all drug supply, which are mostly generic medicines in the United States, over 90% of all medicines are generics in the United States. We take pride in being the leading provider in that sense of affordable medicines in the United States and in the 60 markets we operate around the world. Secondly, it's regarding supporting new technologies that can help improve access, both in the affordability space. So through Sonara Ventures, we have a startup called TaylorMed, which helps patients navigate the financial journey of chronic diseases in that sense. So especially in the United States, where that can become quite available. So they're using AI and big data data analysis to be able to help patients and providers improve access to for patients that need assistance with navigating the financial journey and making sure they can afford it. We also have a company called My Home Doc, which is a telemedicine device which can develop countries to improve the healthcare and diagnostics. The third element with regards to access is also partnering with local governments or local communities and providers to really help develop new ways of providing health and to ensure that the medicines that we are able to provide and others are able to get in their hands. Just one example from the United States with a partnership we've done over the last 3 years with Mount Sinai Clinic in New York, where we've really worked with them to develop new ways of being able to treat multiple chronic condition patients patients that have that are suffer from over 3 diseases or more at the same time? How do we treat the patient as being? How do we treat the patient being in the center, and then make sure that that patient has everything they need and doesn't have to go to multiple doctors, which I think is especially important now, where the patients are not able to go visit doctors as frequently and as easily as they would normally. So really trying to be able to help multiple chronic condition patients deal with their needs on an ongoing basis.
Does Dr. Rabbani or Mr. Andrej want to take up that question also?
Yeah, so perhaps from my side, with the digital platforms, it's pretty easy to talk about the access. So all our solutions are pretty much available on the App Store and Google Play on the internet. And majority of our solutions are free to use to the end users, so the patients, employees, members, and so on. Because we are oriented business to business, so the solution is paid by one of the healthcare providers and employers, or the system that provides such kind of service. And that was our goal from the beginning, to offer it worldwide to any individual that can need that, or a group, or organization, or healthcare that would like to provide something to increase the patient outcomes.
Short at this one, if that's okay with Matondo.
Yeah, that's fine. Go ahead.
Sure. Very quickly, since we run emergency rooms, for our processes, we have formed customer councils. So we ask visiting mothers along with their children, what do they think about our processes? And it helps us get feedback while they're waiting, the queue management system. I think that's very useful because it keeps us humble. I think community engagement in that sense is very important. And I have a question for Elizabeth. I had put in, Rasheeda. I put it in the chat box. I wondered if Rasheeda, you were able to see that. And Matondo, can you help us understand the numbers at the top where it says 7/9 and 18? What does that mean?
Can you repeat that again?
I can help you with that, Dr. Rabbani.
Sure.
That's the 7/9 is the number of speakers here. So we are allowed 9 speakers. So and 18 is the number of people. We do have people coming and going in the session.
Okay. Will we get a chance for people to ask questions?
Yes, absolutely. So whatever
if they have any
questions, they will be able to put it in the chat, and maybe Matondo can. You can look at yourself as well.
Okay, thank you. It's a first experience for me on this platform, so.
You're not alone. It's a bit unnerving, you know, as we've transitioned into this virtual reality. There's so many things that are lost and many things that are gained, but it's all new, right? So you're not alone.
That's actually a very great transition to our next question, which was going to be, how has your work been impacted with the COVID-19, and what are some of the challenges that you've been facing, and what are you doing to lessen that impact? Yes, Dr. Rabbani.
Since we run emergency rooms and for children, and we run 10 of them, when COVID broke out, it became obvious that we were the last line of defense, because a lot of government OPDs closed down. People were afraid to bring their children, even with sign of symptoms, which was suspicious of COVID. So we had to very quickly do 3 things. One, create within ERs a green zone and a red zone, so that the COVID suspects were treated in the red zone. And we had to provide PPE for our people, the staff. 28 of our people got COVID, and another 20 9 had to be quarantined. So in that scenario, we had to handle anxiety. That was the biggest killer. We had to celebrate our people a lot to keep their motivation high, and slowly and gradually we were able to do it. What COVID has hit us because of the bad economic situation, a lot more people cannot afford private health care. So the number of patients coming to us in free hospitals has increased. So that's the challenge for us.
And then I saw Matty Gill with your hand up.
Sure. Thank you. I think, maybe I'll take it. We're all dealing with a new reality on a personal level, and how do we get complicated matters done, whether internally within our company or with external partners, without ever meeting face to face. I think we're all learning that we can do a lot of things in new ways of working without traveling, without going across the world, and ourselves also spend a little bit more time with our families, which is obviously some of the upside in the reality. Instead of having to travel across the world to do face-to-face meetings, we're learning we can get things done without doing that. But also on the global perspective, so we're the largest provider of medicine, the largest producer of medicines in the world. So for us to be able to maintain over 60 factories in various different countries operating has necessitated us to really manage those processes and dialogue with governments and regulators to ensure that our workforce can reach the factories and the R&D centers that they operate in, and to make sure that they're able to be open. And we have had challenges in that sense, and had to invest in how we do that, how we dialogue with the government and make sure that they but also to ensure the safety and health of our employees around the world. So we've had to invest in personal protective equipment, train our employees, of course, work with those type of equipments where it's quite challenging. And we're learning as we go along to ensure that our people stay safe and healthy and are able to continue to provide medicines around the world.
Thank you. If the ladies want to take it also.
Sorry?
So if Ms. Chisomo or Rasheeda would like to take up that question also.
I would actually like to say something along the lines of our expectations. I think that what's been surprising is how well some of our activities have been able to continue. I think that what I've noticed in the United States is that when we think about technological advances, countries in Africa aren't usually the first place that people think of. But mobile technology has been booming all over the continent for a while. And so as we've shifted to this more virtual reality, as I mentioned earlier, we found that some of our practices, some of the things that we've been doing for the last 3 or 4 years have been able to remain. And so our consultations, our touch points, because of the fact that we're continuously working across transcontinentally, like those things stayed in place. And so we have had to shift a little bit of what happens on the ground. Obviously, there were no in-person experiences this year. Usually I'm able to travel and facilitate some interactions, and that wasn't able to happen. But I actually want to say, surprisingly, we've adapted really well and leaned into technology. And it's wonderful to see my African colleagues just take over and be and rise up in this moment.
So it has been interesting with technology and community. I would say the great thing that we are understanding as providers is that our moms are super busy. For a lot of moms, this isn't their first baby. This can be number 2, 3, or number 8. So having the ability to come online and do some educational classes or support groups or telehealth appointments or any of those things have been super convenient for our moms. So I think that has been a win for us. Also really figuring out that ways of traditionally registering for events. Like even how we register for this event, you know, we go online, we fill out a registration form, kind of cutting those things in half. And I honestly just have my moms text me, you know, because that is very normal for them. Hey, just shoot me a text and I will complete the registration, or I'll get all the information that I need there. So we have really high engagement because of that. I would say just on the clinical side with telehealth appointments, even though it's convenient, it's strange. It's strange doing a belly check, standing up in front of a camera, lifting up your shirt for a pregnant woman so that, you know, the provider can get an idea. It kind of seems impersonal that we're hearing from a lot of our moms. But having this hybrid model of, you know, doing telehealth when it's convenient, but also having the ability to come in, makes our moms feel more secure and, of course, safe.
Maybe I can ask Rasheeda or anyone else a question here, if that's on this point. You know, we've seen that healthcare is probably one of the last areas and industries to really revolutionize using digital and telemedicine type of technologies. Do you think COVID might be a facilitator in really helping to train both the professional staff and the patients to work in new ways? I would say, you know, maybe even a catalyzer in that sense, to be able to bring a revolution that might have taken another decade to happen much more quicker.
Or more, more than a decade. I think because of HIPAA, we're always told what we can and what we can't do. And I think that the healthcare industry in general, there's always this immense fear. I mean, which we should be afraid of patient, you know, information of things getting out. You know, what would happen? What are the legal ramifications of that? But then when the world changed with COVID, we have to think of these new ways in order to make things work. So it has been amazing to me that we were told we can't do telehealth appointments. This can't happen. And then March, COVID hit and boom. Now we're doing 80% telehealth appointments or whatever. So it is very interesting that it moves so quickly. I think the other thing that has really propelled more conversation, especially when it comes between clinical and community, is not only how we can have these telehealth appointments, but also how can we connect with the community organizations automatically through referrals? How can our systems talk to each other so that we don't have to do all of this footwork in order to make sure that the patient is taken care of holistically? So even now, thinking ahead, okay, now we know that we can do this and we are protecting patients' information and we are doing the right thing. Now, how can we connect with other organizations that will continue to help our patients outside of clinical care?
I'll add a point to that. I think more than the community, it has changed the behaviors of doctors. We run telemedicine in research rooms for 20 hospitals. Previously, our best doctors would feel that they don't want to be armchair doctors. They always wanted to touch and feel the babies. Now, and 70% of physicians are women. They're finding it not only acceptable, but also for increased access, increased quality, maybe the best option available. It gives them an option to work from home, not expose their family to COVID, because everybody's talking about the second wave. So for us, it's really a game changer. And the government has asked us to put a telemedicine camera in all 100 of its hospitals. So for us, it's really a lead. Otherwise, it was always, telemedicine is also ran. Now it has become the main thing.
Matt, I absolutely love this question because patient-centered care is responsive care. It's care that is adaptive, it's innovative. And we have entrenched practices. And so we see that in each of our different industries. It's the same in speech language pathology and audiology. And so we have been forced to do telepractice. And as I said, because of the unique connection of our partnership, I've been doing telepractice for the last 7 years. And so it's been interesting to see my colleagues and other people all kind of get on board with this thing that was supported by our communities in Zambia. So Patient-centered care is responsive, and I love the fact that we're forced into being innovative. Tragedy is not something that we're excited about. We're all experiencing the negative impact of it, but it often calls us to be the best of ourselves. And so this change has been an opportunity for innovation, and it's been wonderful to see the world step up.
Thank you so much to everyone. Unfortunately, our time is running out. It's already 10:30. However, it would be great if all the panelists could reconnect with each other. Obviously, we all have a lot to share and a lot to learn from each other. And lastly, I would just like to thank our sponsors who made this possible: Platform Brewery, Downtown Cleveland Alliance, Supply Side Group, Alma and Bernie, I'm not sure if I pronounced that right, Rotary Club of Cleveland, E10, Taiwan Sister Cities, CIP USA, Margaret Wang and Associates, Team Neo, Peace Corps, 12 Literary Arts, and Growth Ops. And obviously, thank you so much to all of you guys, because this couldn't have been possible without your amazing knowledge and input into all of this. I hope you stay connected to each other, and yeah, thank you.